Switch my Starlink off. Good evening. Hello. I'm Alison Campbell. I'm here on this Instagram Live this evening. I'm Fertility's Group Director of Embryology. I've been an embryologist all of my working life, and I've been part of the Care family since the very beginning, which was 1997. I think that's the same year I got married, so it was a big year. Right, I'm just going to wait for my colleague to join us. So I'm on the ZetaWest Clinic account. Hang on, here he is. Go live with Charles. Charles Kingsland, a professor, is joining us on the Fertility account. Here he is. Welcome.
Hi, Ali. How are you?
Hi, I'm fine, thank you. How are you?
I'm well, thanks. Whereabouts are you? Whereabouts are you dialing in from?
Well, I'm in my garden in Cheshire.
Lovely, lovely.
Yeah, you're not too
Great.
far away across the.
No. I'm phoning in from the Wirral, just across the road from across the water from Care Fertility in Liverpool. So I'm the group clinical director. My name is Charles Kingsland, and I consult at Care Fertility in Liverpool. So we've got a lot of questions tonight, which are all to do with testing and treatments for IVF. We'll hopefully get through as many as we possibly can, and if there are any that we can't get through, then we will email later. Is that right, Ali?
That sounds about right. Yeah, so we're here for about half an hour. We've got loads of questions. We've had over 80 questions submitted already. So we're going to work our way through some of those, and then we're going to try and also tackle questions as they come in live. So what we're going to cover, we've got already on the list here, pre-treatment tests, egg quality, stimulation and testing of the lining of the womb, embryo quality and selection, that's my favourite one, unsuccessful cycles and implantation failure, and male factor infertility. So loads to go through. We've got some amazing tech as well to chat about, something that we've got coming very soon at Care London and ZetaWest Clinic, Egg Safe AI, so we'll come to that. And lots of exciting things to look forward to.
I think before we start, if I could just remind our listeners and viewers about evidence-based medicine. We hear a lot about evidence-based medicine, and when you're going through fertility treatment, it can be a minefield and so confusing. You get differing opinion from different people, but one thing you have to bear in mind that everything you're advised about, you're told about, there are risks and the benefits. There is a lot of evidence. There may not be much about evidence about the tests you undertake or the treatments you have, but really evidence-based medicine is where a treatment has unequivocal benefit to you. So when you go and see your doctor or nurse or embryologist, and they suggest a treatment to you, the question you must ask is, what scientifically proven evidence have you got that this is going to do me any good? Like, for example, so if I said to you, it's important you take your folic acid, you should say, what scientific evidence have you got that folic acid is going to do me any good? Well, we've got loads. I could lead you to the library and prove to you unequivocally that if you take folic acid prior to your treatment or prior to trying for a baby, your chances of having a healthy baby are greater than if you don't take it. So there are lots and lots of evidence-based treatments that we use. There are also non-evidence-based treatments that are seemingly beneficial, but there is not hard and fast evidence to prove unequivocally that there'll be a benefit. But there's nothing wrong with non-evidence-based medicine as long as it's not harmful, and as long as you know the benefits and risks of the treatment to you as an individual. Is this going to do me any good? And the world is full of non-evidence-based medicine. not long ago, most of the treatment we had was non-evidence-based because there wasn't scientifically proven evidence that it's going to do you any good. And that's okay. You know, there are lots of treatments, royal jelly, co-oxy Q10, lots of things. And there's even quirkier ones, you know, like eating walnuts and avocados. Do you really believe that eating avocados is going to unequivocally improve your chance of having a baby? There's no evidence. It's not scientifically proven, but it may be a benefit to you, provided you know the risks and the benefits to you as an individual. And that's what we're going to try and tease out today. So what should we ask first?
Right, well, I think that was a really good introduction, and it must be daunting for patients because we have an almighty toolbox in our clinics, and but for each of those offerings we have really detailed and balanced patient information. So, and some of the things we offer have extensive data and evidence. All of them have evidence that we've gathered as well, because we want to demonstrate that it's effective in our own hands, not always by randomized controlled trials, but if there are any side effects, that's also listed in our patient information. So it's important to note, but we're there to walk with you through this and give all the patients the information.
That's right. And Ali and I and a couple of others, we're looking at all our data to be able to give you our own individual scoring system from A to D. So whereas the A treatments are of unequivocally proven benefit, B, as they can be of benefit in certain circumstances, but are not of unequivocal universal benefit. C is where we just don't have enough evidence to say one way or the other. And then D, if there's a treatment or an investigation which we classify as D, that means we don't have any benefit, and in fact it might even be harmful to you. So we try and avoid the Ds, but that's what we would aspire for you to ask when we are offering treatments or investigations. And it all boils down to the trust you have with your doctor, with your nurse, with your scientist, and indeed the clinic. So once you've engendered that trust, then hopefully that you will feel more secure in the decisions that you make. Okay.
Right. How about I fire you with some quick questions like mastermind or something like that?
Pass.
So, what's the difference between AMH and AFC?
Okay, so there are only three major tests you need when you're wanting to assess your fertility. And the questions you need to ask is, have I got eggs in my ovaries? Are all my bits in the right place? And do the sperm have the ability to swim up to my egg? And they're the three tests. So a semen analysis, a pelvic ultrasound, and then a test of what we call ovarian reserve. That means it gives us an indication of the number of eggs that the female might have. It doesn't tell you about the quality of the eggs at all, but it might tell you about the number. And the two tests are AFC, that's the antral follicle count, and we scan you. That's assessed by an ultrasound scan, and it looks at the number of antral follicles, the little fluid-filled sacs that surround the outside of the egg. And there is a correlation between the number of antral follicles and the ovarian reserve, the number of eggs you might have. So we want to see a healthy number of antral follicles. AMH is anti-Mullerian hormone, and that's the hormone that's produced by the cells that surround the egg. And that's a blood test. And the more AMH you've got, the more eggs you've got. Again, it doesn't tell you about the quality. It might be far better to have a low AMH with good quality eggs than a high AMH with poor quality eggs. But it gives us an indication of what we call your ovarian reserve. Antral follicle count and AMH. Some clinics use them together. Some clinics have a bias towards one or the other. Personally, I like AMH, but I also like a backup of AFC. But they're both very, very useful tests to have. And they are, I would say, they are essential as part of your basic investigations.
And the next question leads on nicely. So is there anything we can do about the AMH level? Can it be improved?
No, you can't improve an AMH test. You can only prevent it getting worse. So we have our egg store, our full egg store on the day we're born. We don't have the ability to make eggs. We only have the ability to lose them. So the biggest factor in causing a reduction in your AMH is getting older. But there are certain things that don't help. Smoking, being over, having a high body mass index, being a little bit overweight, or getting older, and poor diet, or if you've got any nasty diseases, endometriosis can affect your ovarian reserve. If you've had any serious illnesses that have required chemo or radiotherapy, that can affect your AMH. But the important thing is to protect it. Good healthy diet, don't smoke, moderation in alcohol, and try not to get old.
Oh.
Yeah.
There's lots of great, there's lots of great information about nutrition on the ZetaWest Instagram lives portfolio. There's really some great stuff there, so we won't go into great detail tonight about that, but recommend that people look at that. So thinking about egg quality, we're saying that there's not a lot we can do about it really, other than look after ourselves. So when we've collected eggs, patients always ask, well, how are my eggs? And I always used to say, well, the proof is in the pudding. Once we try and inseminate them, if they fertilize and develop into nice embryos which are transferred and result in a baby, that's really the only way to be sure about the quality of those eggs. But things are changing a little bit now, and we've got these exciting tools like artificial intelligence, which is giving us much more insight. So things that we can't necessarily see down on microscopes, computer vision is detecting. So we're really excited, and soon we're going to be launching EggSafe AI. So this is using artificial intelligence to assess egg quality. And if we say there's not much we can do about it once we've got the eggs in the lab, but it's really interesting and useful information, particularly for patients who are thinking of freezing their eggs, which is why we've linked it to EggSafe initially. So EggSafe is our egg freezing product. So what the AI solution gives is, apart from a beautiful report with images of all the eggs, it gives them a quality assessment. And we've put it through its paces, Charles, because you know, we were a little bit cynical to start with, and I thought, how can a computer know more than me or my colleagues? We're experienced, but it does. So we've used lots of our own data where we know what's happened to these eggs, and we've tried to predict it compared with the computer vision and the AI solution, and it's done far better than us. So it's really helpful, potentially for patients thinking about how many eggs to bank and just trying to set their expectations.
Yeah. I think, one of the things that never ceases to impress me, Ali, is the quality of science that are in the care laboratories, particularly when you talk about artificial insemination. Because from a clinician's point of view, from a doctor's point of view, you know, I get it. And once we get it, and we can transfer that information to the patients, and then they will understand it. Like, for example, Caremaps, which I think is brilliant. While we're here, can you just tell us a little bit about Caremaps, because you know I love it for patients.
Yeah, Caremaps. It's taken a decade to get to where we have with Caremaps. It's gone really quickly, and it's moved at such a pace. It was magnificent 10 years ago, and now it's in another league. So basically, it's something we've developed using time-lapse imaging. So you might have seen those time-lapse photos of flowers unfolding over time. It's exactly the same. So it's an absolute privilege to see this for an embryologist or for anybody. When you see the embryo developing in the same way, a short video, but we've been able to identify the specific patterns of development and the timings which relate to viability, to healthy embryos, and to implantation and to births. So we use these tools that we've developed to make sure we select the embryo that is developing in this optimal way, because most patients, fortunately, they have a number of embryos, and it's so crucial that we choose the right one first, shorten that time to pregnancy and birth, and freeze those embryos that are also high quality. So Caremaps, it's algorithm. It's a model that we use, that we've developed in-house on thousands and thousands of pieces of data, and 8,000 babies born. So it is magnificent. It's highly successful.
And this is a classical example of where we talk about evidence-based medicine, because it's not going to improve your chance of having a baby, but what it helps us to do is to pick the embryo that's been created. We can't make that embryo better quality, but it helps us to pick that embryo that is most likely to turn into a baby, and that can save an awful lot of heartache and time, because it enables us to get you pregnant quicker. And that's why it's such an important test, I believe.
Yeah, well, a question just came up. It's an interesting one. It says, can you detect genetic abnormalities using Caremaps? Well, the very first version of Caremaps was designed to give a risk ranking of genetic abnormalities, aneuploidy it's called, based on the patterns of development. And we published this, we were all over the news. It was a big story internationally, because it was the first time that we've been able to assess the risk of an embryo being genetically or chromosomally abnormal, just in a non-invasive way. So I mean, it's not binary, it's not yes or no, it has a higher chance of being chromosomally normal, balanced, or not. So it was amazing. But we've moved on now, and we're using our algorithms to predict babies and births, healthy births. So yeah, I do believe there is, it can indicate genetic abnormalities in terms of aneuploidy, but it's not as precise as genetic testing for aneuploidy. So it's a non-invasive alternative to predict the best embryo, and part of that should be its chromosomal complement. So I hope that wasn't too complicated. But
what it can do, though, Ali, is reduce the chance of putting back an abnormal embryo, and hence reduce the chance of miscarriage, which is, or again, the evidence is not unequivocal, but there is a very strong relationship between Caremaps and reducing the incidence of miscarriage. And as one ex-patient has said, she loved the video of her embryo, because one thing that we can do, of course, is we video the growth and development of the embryo, and the patient can see that, and it gives them some reassurance as to how their embryos are growing. That also enables us to choose which embryos are good enough to freeze, and there is a significant improvement in the outcomes of frozen embryos, to the point now where I would say that the technology for freezing and thawing embryos, the pregnancy rates are as good, if not better, than fresh embryos. And the reason behind that, and Ali, you can criticize me if I get this wrong, but when you stimulate ovaries to get eggs as part of the IVF treatment, and there's evidence-based that stimulating ovaries is better than just collecting eggs naturally. There's plenty of evidence to suggest that you're better off having your ovaries stimulated. And then we collect the eggs, and then we fertilize the eggs and put the result one embryo back. You're actually not always putting that fresh embryo back in the best environment, because sometimes those hormones that have stimulated your ovaries may be good for your ovaries and good to collect eggs, but might not be good for your endometrium, the lining of the womb. So what we're doing at Care Now and in Care Fertility in Liverpool in particular, we're segmentalizing the IVF so that we create the embryos, we then grow them in the Caremaps to 5 days old, and then we freeze them, so that the patient can go away, recover from the egg ovarian stimulation, and then come back 2 or 3 months later and have their embryo thawed and replaced in the optimum endometrial environment, an environment that is in sync with the embryo. Now, again, that makes a lot of sense to me, and the tests that we can do for synchronizing that endometrium are new but very persuasive. And one of the tests that we do at Care in particular is endometrial receptivity. So what essentially we do is we simulate a frozen embryo replacement cycle, and instead of putting the embryo back on the day we want to, we do a biopsy. And that biopsy tells us whether the endometrium is in sync with the embryo. Is that endometrium mature enough to receive that 5-day-old frozen thawed embryo? And whether it's delayed by 24, 48 hours or advanced, so that it enables us to put that embryo back in the subsequent cycle at exactly the right time. But it also gives us another 2 bits of very important information. It tells us whether there's evidence of infection in the endometrium that we don't know about, in which case we can treat it with antibiotics. And also, importantly, it tells you about the patient's microbiome, which is a very important subject that is getting more prominence nowadays. And your microbiome is your own population of bacteria. We all have our own microbiome, our own friendly, good bacteria. And sometimes if we take antibiotics at the wrong time, we may wash out not only the bad bacteria, but our good bacteria, and leave great big holes for bad bacteria to go in and grow. So what we want to know is what your microbiome is, and if there's a right population of the right bugs. And we can modify your microbiome by from the information we get by asking you to take probiotics for a couple of weeks, so that when your embryo is thawed, after we've care-mapped it and categorized it into an excellent embryo, we can put it back into at the right time, in the right place, in the right environment. And we're getting great success with that. So people should never be under any illusions that having frozen embryos is in any way detrimental. It can be a very positive thing.
Yeah, brilliant.
Yeah, I'm a bit passionate about frozen embryos and good endometrium, and it all makes complete sense to me. And often the most simple tests are the best ones, because I always find that, you know, if you're being asked to do lots of complicated tests that you don't understand yourself, the chances are that we don't understand them either, and therefore they may not be of great benefit to you.
Yeah, should we all be taking probiotics, do you think, Charles?
Do you know what? I think we should. I think this is going to be the next big thing. You know, when you're a doctor or a gynecologist or a fertility doctor, new things come along about lots of new things come all the time, and we're going to hear about the new things that are happening in the lab, which are, some of them are sensational. But every 4 or 5 years, something that will come along, which is a real game changer. That means that we alter the way we practice, like frozen embryos, like vitrification of embryos, like Caremaps. And the next thing, I think, is probiotics. And there's lots of very important information about your microbiome, not only for fertility, but for general health, for gastrointestinal health. You know, when we all saw those adverts for Danone and all that sort of stuff, we thought they were a bit daft, but actually now they're becoming really important. And there's a lot of evidence now that the vaginal microbiome is very important to prevent premature deliveries. Often, women who get pregnant, some women will rupture their membranes prematurely and deliver babies. Well, there's some evidence to suggest that might be due to an abnormal microbiome in the vagina that is creating a microinfection in the amniotic membrane, which causes it to rupture prematurely. And simple probiotic therapy might alter that microbiome and prevent that occurrence happening again. And I think the same we're going to see that in the future. Now, this would be category C information. We don't have unequivocally proven evidence, but we just don't have enough evidence. And it's a bit like COVID. Do we take COVID vaccine in pregnancy? We don't know. We think it might be fine. We have no evidence that it's going to be harmful. We just don't know. We don't have enough evidence. And the chances are it will be fine when we've collected that evidence.
Yeah, brilliant. There's lots of questions. It's sparked quite a lot of interest, I think, the probiotic discussion, but that's great. So I do think people should look at the ZetaWest accounts for more details on that. That's really
yeah, definitely. And yeah, look at the ZetaWester account, because they're really hot on nutrition, and we can benefit as a group. We have 21 clinics, of which, you know, ZetaWester are the pioneers in nutritional therapy, and we can benefit whether you're having treatment in Northampton or Tunbridge Wells or London or Liverpool or Manchester, because we have, you know, ZetaWest is part of our family. Have a look on the website, on the Care website, about endometrial receptivity assays, ERA. I think it's important. Yeah,
and also on our social media accounts, there's a whole lot of stuff about embryos. We've done lots of lives talking all about the embryo and selection, and so have a look there for more information on that.
Yeah.
So a few more questions for you, Charles. Right, this patient only ever got one embryo to day 5, age 36, low AMH. What would we recommend?
Right, well, the chance, so you may have a low AMH, which means that you have a relatively low number of eggs, but they're 36 years old. So they may be of reasonable quality. It's just a question of finding the one that you that is good. We just need one. One of the things that we would think about at Care would be to offer something called DuoStim. Now, I don't know whether this is right for you, but it might be something that's worthy of having a discussion with, and that's where we undergo an IVF cycle and we stimulate your ovaries once and collect the eggs, but instead of you going away and having those eggs fertilized, those eggs are then fertilized, but then we stimulate you again straight afterwards, and collect the eggs from the second stimulation. So the idea is you stimulate, you collect, and then you stimulate again, and that stimulates those little tiny immature eggs from the first cycle that may have needed just a little bit longer to grow and develop to the second cycle. So we catch them all, and there's some evidence, not enough to prove unequivocally, but there's some good evidence to suggest that those eggs from the second stimulation are the good ones. Mm-hmm. So at the age of 36, I would, if I were you, I would get some advice as to what you need to do next, because the next cycle is the big one for you, and DuoStim is something that if you were at Care, we would be discussing with you. It may not be right for you, but we talk to you about the risks and the benefits, the chances, and then we make the decision together.
Yeah, that sounds good. And it's not really clear whether there are a good number of eggs collected and fertilized, but it's embryo development that's the problem. But whatever it is, we have some options that we believe firmly in. So we'll
yeah. Can I just ask you then, Ali, about oocyte activation? Do you think that's something that we could offer in these sort of circumstances?
Yeah, it's really new. There's limited data, but it's really interesting and promising. So yeah, in a small number of cases, we have used a solution. It's like a culture medium called artificial oocyte activation, not for activating the eggs during fertilization, because that's one application, that's the most established application, but to encourage embryo development if we've had poor embryo development in the past. So we're moving quite steadily with this, and cautiously, fully informed, gathering the information, keeping abreast of the literature. But it is available, and it seems to be working really well for those cases which the embryos, we get a good number of embryos, but they just don't make it to the blastocyst stage. And that's the stage that we really want them to get to, because that's when the implantation rates are the highest, and we have the best methods to select the best one. So yeah, definitely an option for some situations like that, Charles. Yeah.
Yeah, we've got a lot of questions here on PGT embryo testing and mediocre quality. Fancy being told that your embryos are of mediocre quality. Is this because my eggs aren't the best? Well, there are a lot of reasons why embryos might be of the best quality, but there again, the best quality tends to be the best chance. But I've seen poor quality embryos turn into beautiful babies. So don't give up. Just speak to your gynecologist, speak to the embryologist, and see whether we can build on the information we've learned about your embryos to make another cycle better. That might be the case. I don't know, but it's certainly worth having the consultation. Now it's 7 o'clock, Ali, and we've got loads more questions.
Well, shall we just talk quickly about sperm for a few minutes?
Yeah, okay.
Because we were talking earlier about semen analysis, and it was one of your top 3 essential assessments.
Yeah. Okay, let me ask you the question then. How can you test for sperm mobility? Mobility,
also called motility, we can test by looking down our microscopes. We have counting chambers, and we can see. So sperm are magnified, so we can see how they're moving, and we're very experienced at assessing whether they're progressive, whether they're moving in a particular direction or going in circles. We've also got a computer-assisted semen analysis device that we're implementing steadily across the group, which helps with that and gives us lots of images and data, which can help with a detailed semen analysis. And we also have fairly recently introduced a wonderful test, sperm oxidative stress testing. And I think it's excellent. It just gives us information that we can act upon immediately if there's an issue. So I know you're quite a fan of this one, Charles, aren't you? Because you've been offering it to patients. And so if we get a raised result showing that there is potentially oxidative stress on the sperm, which can affect their quality, their potential, then we can treat the guys with antioxidants.
Yeah.
But it's not recommended to self-medicate with antioxidants. And we know that some men do this, either because they've read an article or maybe the GP has informed them. It could be that you need antioxidants. And that can have a really negative effect if you don't need them. So this simple test that we can do at the time of semen analysis will let us know whether it is necessary to have antioxidants or not.
Yeah, I mean, more than anything, it actually tells you when you shouldn't be treated, because, as you said, Ali, just taking zinc and vitamin E willy-nilly may not be good for your sperm if they're not stressed, because you're overdosing them on antioxidants. So I think for me, it's an essential part of the investigation of sperm, because I think, we tend to overdo the female investigations and underdo the men, and men have been neglected for a long time, and just on the basis of one sperm test we say, oh, that looks fine. It doesn't. I think there's more to it than that, and you're right, CASA that we use in Liverpool, across the board, gives you some really useful information. And the other nice thing is you can actually see your sperm. Again, you've got a video of looking at your sperm, so we can explain it all to you, which helps, it certainly helps me anyway. Is surgical sperm retrieval safe? Yes, it is. It is safe. Any good supplements to increase men's healthy sperm count, morphology, motility? Well, we've been talking about that, but most important thing, keep your testicles cool. Don't, not too much alcohol. Certainly don't smoke. Don't do too much excessive exercise. Don't take protein additives and steroids. They're really bad for your sperm, and we've gone on about this ad infinitum on previous Instagrams. Micro TZ is what it says. It is a when we're looking for sperm in the testicle, so when there's no sperm available in the ejaculate and we're looking for sperm in some circumstances in the testicle, there is a technique called micro testicular aspiration of sperm, where you can, with great big binoculars, you can go and search for the lonely wandering sperm that may be there that we couldn't see under a normal microscope. Again, it's not evidence-based. The jury is still out, but it is a potential therapy that that is in our armory if we need it. But again, before you embark on these sort of tests, you need to, when they're non-evidence-based, you need to know the risks, the benefits, the cost, what the likely outcome is, and then we can all make the decision with people that you trust.
Yeah. Right, I think we better sign off for this evening, but it's been wonderful to be here. It's been a while, but I'm sure we'll be back soon with lots more news, lots going on. And don't forget, everything's available on our website. Lots of useful stuff on Care IGTV and the website. So anything else you want to say, Charles?
Just to say that, thanks, Ali. I learned a lot. I think AI is going to be really interesting. It's going to be a very important addition to what we can offer patients. We'll try and answer as many questions afterwards as we possibly can. And thanks for tuning in and asking all those questions. I hope we've answered a few to your satisfaction, and I'll see you again soon, Ali.
Yeah, see you soon. Thank you.
See you soon. Have a nice evening. Have a nice evening, everybody. Bye.
Thank you. Bye.